clinical part of the evening, I'd like to welcome Associate Professor Diana Learoyd. Di is an endocrinologist who's been at Royal North Shore for several decades, and she vastly experienced. Vastly experienced. She completed a PhD in 1999 in the genetics of thyroid cancer and in multiple endocrine neoplasia type 2. She set up the thyroid cancer clinical database at Royal North Shore Hospital with the New South Wales Cancer Institute grant, and she's had a major role in the TKI trials that we run at Royal North Shore Hospital for both papillary follicular thyroid cancer but also for medullary thyroid cancer, the different subtypes of thyroid cancer that we see. She co-runs the Thyroid Cancer Multidisciplinary Clinic at Royal North Shore Hospital together with Mark Sywak, and she's got an extraordinarily busy and diverse clinical practice in general endocrinology, but with a focus on thyroid cancer management. Di, thank you.
Well, thank you very much. It's a great honour to be here, and it's great to see the audience. It's also good to redress the gender imbalance on the panel, given that we deal with so many women as patients. But so yeah, as the token female, I'm very honoured to be here. So this is my topic, who needs minimal treatment? And I'd just like to draw your attention to my declarations there. And also I'm aware of the fact that in the audience there are some non-medical people. Can you put your hands up? Yep. So I won't be going through the very basics of thyroid cancer management, but we do have a handout, which is this article that we've recently written, which is fairly user-friendly for people, whether you're expert or not in the area. So how do we minimise therapy? So we minimise it by not doing any surgery in a thyroid cancer patient, by doing a hemithyroidectomy, so half the thyroid is removed instead of the whole thyroid, by doing a total thyroidectomy without radioactive iodine, or by doing a total thyroidectomy with a very low dose of radioactive iodine. Now, this is in contrast to what we used to do, which was one size fits all. And yes, I have been around for several decades, and so I remember the sledgehammer approach, where every single patient, no matter what their age or stage, received total thyroidectomy with 6 gigabecquerels or 150 millicuries of radioactive iodine in the old days. Nowadays, it's all very different. It's tailored and it's individual, and it's based on evidence. And why is that? And that's because we don't want to be in this scenario where the treatment is actually worse than the disease. And that's particularly relevant for thyroid cancer, where the outcomes tend to be very good with minimal treatment. And you just need to be aware that there are some long-term sequelae. They're very unlikely, Amber, so don't worry. But yeah, we try to go with the best possible evidence and the minimum treatment that will work. And Rory's already alluded to this. Thyroid cancer is becoming more prevalent. It's a disease of all ages, but it particularly affects middle-aged women, and it affects women in their childbearing years, and that's very relevant to how we approach management. So we really do have to tailor our management to whether a woman or a man is planning a family and when they might want to have children. However, the news is that the outcomes are excellent. So no matter what type of thyroid cancer or stage, you are unlikely to die of it. If you have low-risk thyroid cancer, the death rate is close to 0. If you have high-risk thyroid cancer, it's still less than 50%, although along the way, it is quite likely to recur. So you may need to have more than one mode of therapy at more than one time point. If you're diagnosed under the age of 55, your 10-year survival is very close to 100%, and even if you're diagnosed with distant metastases at that age, it's close to 85%. So it is pretty good news. Not always. In older patients, not so much, but in young patients particularly. We're very lucky that we have evidence-based guidelines from the Americans that help us in our approach to tailored management. So these guidelines have been going for quite a few years now, and they're very comprehensive. They're updated regularly. The Americans, particularly this guy, put a lot of effort into them. In fact, Michael Tuttle has said that he's now spent so many weekends on doing guidelines that his wife's threatening to divorce him. So we may not see the next version with him on it. So how do we come to see these patients? As you all know, we see them because they present with either a lump or they have an ultrasound finding such as this, or both. And this is a thyroid cancer. You can see it's between the artery and the trachea. It has an irregular border, and a patient with this finding will then proceed on to have a fine needle biopsy plus or minus an operation, which may be partial or total thyroidectomy with or without lymph nodes. I'm not going to go into cytology or pathology or choice of surgery tonight, but that may come up in the discussion. And I also don't want to impinge on Mark's talk. So we, as an endocrinologist, we often see the patient pre-op, but we always see the patient post-op. And we may or may not have the benefit of a histopathology report that includes the lymph nodes, and we're very lucky at North Shore that our surgeons routinely remove central lymph nodes if they know the patient has cancer up front, and they can do that with very minimal morbidity as opposed to some centres around the world. I'm very indebted to Lee Delbridge for his slide where he's nicely illustrated the central lymph nodes that are usually routinely removed, and that allows us to have a bit of a better idea about staging. So the cross has moved. So what I want you to know is that cervical lymph nodes are not metastases. So the cross is meant to sit on top of the word Mets. They're very common, particularly in papillary cancer. So papillary cancer is the commonest cancer. It's the best prognosis, but it has the highest incidence of lymph node metastases. And despite that, it does very well. Less so in follicular and Hurtle cell. Lymph nodes are concerning, but they're not always bad. They don't upstage your risk unnecessarily if your tumour itself is low risk. And they have minimal impact on your TNM stage, ironically, if your tumour is low risk. We also have thyroglobulin, a blood test, which is a very useful tumour marker, and it responds to therapy over time by going down to 0, hopefully. We can also measure it in fine needle biopsy washouts. So if someone has a recurrence suspected in their lymph nodes and the cytology is equivocal, we can actually measure thyroglobulin in that lymph node washout to get extra sensitivity on diagnosing recurrence. We also have very good assays for serum thyroglobulin now that detect thyroglobulin levels less than 1 microgram per litre, although we do have to be a little bit careful about thyroglobulin antibodies, which interfere with the accuracy and falsely lower the result. I think most of you in the audience will be aware of that, of this thyroglobulin information. Okay, so in terms of who needs minimal treatment, people with low-risk disease will need minimal treatment, and I will be moving on to describe some cases that I currently manage. And in the guidelines, this is what is listed as low risk. So it's logical. All the tumour has been resected, there's no local invasion, and it's not one of the unusual aggressive histological variants, which I won't go into. And we now have some new categories that have crept into this low-risk category. So the low-risk category keeps expanding, which is really good news, as we get extra information from trials to show that some things are not as bad as we thought they were. So, for example, you can now have some vascular invasion with an encapsulated follicular cancer and still be very low risk. So it's good news. Intermediate risk is any of these things, and now in the latest iteration of the guidelines, you have to have clinical lymph node involvement to have intermediate risk, and these things also logically will upstage you to intermediate, such as tall cell variant, etc. Vascular invasion on the pathology concerns us and usually upscales you to intermediate risk, except for the example I've already given you for low risk. And in the latest guidelines, we actually, for the first time, have the mention of this genetic mutation called BRAF, which you'll be familiar with, is a common mutation in other cancers. It's quite common in thyroid cancer, specifically papillary thyroid cancer, and it actually does rate a mention now in intermediate risk category. I'm not going to go into that in great detail, but I will make the point that risk is always reassessed. So when you stage someone at the beginning, you may think they're high or intermediate risk. If they respond beautifully to treatment after a year, you can downstage them to low risk. So it must be reassessed dynamically, And there's good data now to show that delayed risk stratification according to their response to treatment is a much better way of predicting their outcome rather than just going on what happened right at the beginning. I won't say much about TNM. It's about to be upgraded to edition 8. I don't find it particularly useful myself. It's used in other tumours. It's designed to look at mortality, which doesn't really suit thyroid cancer. It's very black and white. If you're under 55, everything's great. If you're over 55, suddenly it all changes, and we know that's not really how it happens. So TNM, not that useful in my experience. We've also just changed the magic age from 45 to 55, so it's a little bit arbitrary. In reality, though, it's much more like this. So it's a gradation of risk from the best possible risk, which is a unifocal micropapillary cancer, right up through low, intermediate and high, up the top here. Don't worry about reading that. That will put you to sleep. Okay, and the other things that we consider, apart from what I've already mentioned, which is age, stage and histopathology, we also look at gender. Unfortunately for you blokes, men tend to do a little bit worse than women. Family history is very important. Radiation exposure to the neck is also very important. And genes are becoming more and more important, and I'm sure that will be covered a little bit later in the high-risk sort of patients that Bruce will probably cover. So you probably already know that if you've had external beam radiation to your neck as a child, that your risk of thyroid cancer is significantly higher than the average population. And also if you've been exposed to nuclear fallout, such as Chernobyl in 1986, or even Fukushima. We're now seeing some data from Fukushima in Japan from coming through now for thyroid cancer. Luckily, most of us here haven't been exposed to that, although I did see a patient on Monday who actually lived in the Ukraine in 1986, who migrated to Australia in 1996, so you never know when it might come up in the conversation. And genetics, again, I won't touch on this in detail. So BRAF, I've already mentioned as in the intermediate category. What does it actually mean? It's very common in thyroid cancer. It's common in very low-risk cancers, and it probably doesn't help to know your BRAF status if you're very low risk or high risk, except perhaps for tailoring treatment in high risk patients. But we think that it may have some prognostic utility in intermediate. So these are the patients who maybe have lots of lymph node involvement. We're not really sure how things are going to behave in the future, and how to give them an idea of how they're going to travel. That's all I want to say about that, except to show you this, this slide. So Anthony Gill in our pathology department at North Shore routinely does BRAF immunohistochemistry now on all papillary thyroid cancers. So radioactive iodine is the other area, and Geoff will cover this later, and I won't go into detail. The guidelines state fairly clearly radioactive iodine is fairly routine for high-risk patients. For low-risk patients, we no longer recommend radioactive iodine for unifocal or multifocal papillary microcarcinoma. That means less than a centimetre, in the absence of other adverse features, and the literature would support this. And it's not recommended for patients with low-risk differentiated thyroid cancer in the absence of other adverse features. And there are some ongoing studies that will hopefully reiterate that. We consider it in intermediate risk patients. We tend to give it at North Shore because I think we're sort of used to doing that and people do well, but the evidence now is that we don't always have to give it as much as we did. This is a patient of mine who looked like he was going to be low risk because he was young, but he had previous radiation to the neck and he had vascular invasion on his micropapillary cancer. And after radioactive iodine, I'll just go back up, we had an unexpected finding of a lymph node that had been sort of left behind. This is some years ago. So, and he's been cured just with a single operation and single dose of radioactive iodine. And the dose is very controversial, and Geoff, I'm sure, will cover that in great detail. We have two very good randomised prospective studies that were published in the New England Journal 5 years ago that helped to clarify that for low risk and intermediate risk disease, a low dose is perfectly adequate. So 1 gigabecquerel, which is 30 millicuries, is just as good as 4 or 100 millicuries. And there's ongoing evidence now. So 5-year follow-up from this particular study, the European study, the French study, is very reassuring, and the British study also included intermediate grade disease. However, old habits die hard, and I've done a snapshot of what we're doing at North Shore, and we're still giving quite a lot. We're giving 4.2 gigabecquerels on average for low to intermediate risk disease, so perhaps we need to gradually move into the 21st century, and I'm sure that will happen eventually. No, most of us are giving low doses for very low risk. I won't go through the guidelines, or you'll definitely fall asleep. They don't really help you a lot for intermediate grade disease. They use a lot of C words, conflicting evidence, and consider giving radioactive iodine, although they're fairly clear that you don't need to do it for low risk, and you probably do need to do it for high risk. So, in the last few minutes, I just want to describe some cases. These are cases I'm currently looking after. First is an incidental finding of a thyroid cancer on PET scanning. This lady is 78. She was seen 6 years ago having investigations for another malignancy. A routine staging FDG PET scan uncovered a hot area in her thyroid, and we see this commonly. So I think the prevalence is about 2.5% for hot thyroid uptake in PET scans performed for other reasons. Interestingly, she actually did have thyroid nodules, and most 78-year-old women will have thyroid nodules on ultrasound, but the hot area was not in a nodule. So the FDG PET uptake was not avid in the known dominant nodule in her thyroid, but it was just above there, and I'll show you that later. If someone has a hot nodule on PET in their thyroid, they've got a 1 in 3 chance of it being cancer. And this is this lady, and this is the area in her thyroid. And she was very keen to have slow or conservative management, so she actually waited a whole year to have a biopsy. We finally got around to doing that, and yes, it was cancer, and there it is again on the PET scan. And this is the ultrasound. So this is not a very good view, but you can see this is the nodule here that you could see on ultrasound, but it's not PET avid. This little area here where there's a bit of calcification was the area hot on PET. That was biopsied, and that was the cancer. She did see a surgeon, and she chose not to have surgery, and 6 years down the track, serial ultrasound has shown no progression, no discrete nodule, and she's perfectly well. And this approach is now quite well supported in the literature, particularly with the Japanese literature. So the Japanese have studied micropapillary cancer, also particularly in older patients, to show that often it just grumbles along and doesn't necessarily need intervention. And people in Melbourne have also studied incidental PET uptake in patients who have other cancers to show that you don't necessarily need to intervene, particularly if the prognosis for the other cancer is more guarded, because thyroid cancer tends to behave much less aggressively. Case 2 is a patient with multifocal micropapillary thyroid cancer, and this is a lady I just saw recently. She's a female physician who works at this hospital. All her family are doctors, seems to be typical of my practice. She had a lump in her thyroid which got bigger postpartum, and she had a benign biopsy, so she had what we call Bethesda category 2, so that doesn't worry us. However, the lump got bigger and was causing pressure. So she came to surgery for obstructive symptoms. She had a left hemithyroidectomy, and the lump was benign. So the dominant lesion was 3.5 centimetres. It was a follicular adenoma, which is benign. An incidental finding was made of 2 papillary microcarcinomas, 1 millimetre or 1.1 and 1.2 millimetres. And the decision we've made together is that she's very low risk and that she will have hemithyroidectomy alone without total thyroidectomy at this stage, but with regular monitoring. And this is her ultrasound showing a very benign looking but large nodule in the left lobe, isoechoic with a clear border. That was Bethesda category 2. It came out for other reasons, and incidental finding of microcarcinoma, which you wouldn't even expect to see on an ultrasound. A similar but different case, another woman in her 40s, she did have an abnormal fine needle biopsy. She had category 4, which is a topic in itself. I won't go into that tonight. So she had a diagnostic right hemithyroidectomy for an atypical biopsy, and she did have a cancer, and it was 1.8 centimetres, encapsulated follicular variant of papillary cancer with some Hürtel cell features. So this is slightly complicated. It looks like a papillary cancer, but it also looks like a follicular cancer. And luckily, there was no extrathyroidal extension, no vascular invasion, BRAF negative. And again, she has elected to have conservative management, hemithyroidectomy alone, and regular monitoring. In the old days, she would have had a completion thyroidectomy, a second operation, and a dose of radioactive iodine automatically. Case 3 is a patient who is very anxious. I think her father's actually a doctor, coincidentally. And Murphy's Law has been pretty unkind to this lady, and she and I have been through a lot of anxious times together. Anyway, long story short, she's 30. She has Hashimoto's disease, which is, as you know, is the autoimmune disease, which is very common in young women. She is antibody positive, and she had her first baby last year and then developed severe postpartum thyroiditis, which is not uncommon. It's about a 30% risk in women who have Hashimoto's disease. However, she, being she, was particularly unwell. She had very high thyroid hormone levels. She was very sick. She did not tolerate the treatment we normally give, which is beta blockers. She actually ended up in Prince Alfred casualty with a systolic blood pressure of 60 after one dose of Indoral. And I actually treated her with steroids, which is the first time I've ever given steroids for postpartum thyroiditis. And she got better very quickly, fortunately. Now, I never biopsy people with postpartum thyroiditis because the gland is very heterogeneous, and there are lots of areas that actually improve and the swelling goes down. But she had a residual mass in the middle of her neck, which was quite firm 6 months later. And we biopsied that, and Murphy's Law being the way it is, it was a Bethesda category 6 biopsy or a papillary cancer. So, of course, she now had to proceed on to total thyroidectomy. Well, did she need to have total thyroidectomy? In this case, I can assure you yes is the answer, knowing her and her family. She had total thyroidectomy with a central node clearance and fortunately was low risk, although she was multifocal disease. So she had a 1.1 centimetre cancer. Also, she had 0.5 centimetre and a 0.1 centimetre papillary cancer with no nodal involvement. She was still breastfeeding, I might add, from the baby last year. And she, again, is low-risk disease. I actually told her she didn't need to rush into having the operation, but she, being she, had it within a week. Thank you, Mark. You do provide very good service. So at this stage, there are no plans for radioactive iodine unless her dynamic risk reassessment actually changes. And at the moment, things are going well, except that because she's antibody positive, we can't accurately monitor her serum thyroglobulin. So her antibodies are positive, but they are waning, so I'm very hopeful, and I'm trying to present it in a positive light because I think she's completely cured. And this is her ultrasound. So you can see she's got a big swollen heterogeneous thyroid from Hashimoto's plus postpartum thyroiditis, and this was the area in the middle that was the papillary cancer. And you really, it was clinically suspicious, although you wouldn't really be able to distinguish that from the rest of the scan. So I probably will finish up there. I'll just mention the last case very briefly. This is another young female who was actually diagnosed during pregnancy, operated on at another institution, told by her surgeon, who's not in the room, that she needed radioactive iodine. It was a no-brainer. And in fairness to him, I think there is considerable confusion now about what constitutes low risk. So I'm not passing judgment on him because he's has her best interests at heart. But at the time, she was pregnant and planning to breastfeed. So all those sorts of decisions are very traumatic for a woman who's got an unexpected cancer diagnosis during pregnancy. So she came to see me with this pathology, for a second opinion, 2.5 centimetre papillary cancer, classical with 1 out of 11 central nodes involved. And I saw her at the end of pregnancy. She then delivered a healthy baby and started breastfeeding. And her thyroglobulin postpartum is completely negative, and we have no plans to give her radioactive iodine unless we really need to. And she has, I think, had trouble accepting that opinion and has sought a third endocrine opinion, but hopefully she'll be fine. So I'd just like to finish. Who needs minimal treatment or no treatment? No treatment is appropriate for elderly patients where the thyroid cancer is very small and not likely to cause any trouble in their lifetime, or in patients who have an incidental finding on PET, particularly if their other cancer has priority. Minimal treatments such as diagnostic hemithyroidectomy is appropriate for encapsulated tumours without vascular invasion, or even for low-risk papillary cancers, and that may include multifocal papillary cancers. And low-risk patients can also have total thyroidectomy without radioactive iodine, but as long as we dynamically reassess them. So we never say goodbye, we keep seeing them. And we also know that from the literature, if we have to do catch-up therapy later on, it probably doesn't matter. So thank you, and thanks to my colleagues.